Now, what is the FDA-approved treatments in the first line for small cell lung cancer? There's 2 FDA-approved treatments in extensive stage. So this is quote-unquote metastatic small cell lung cancer. The 2 FDA-approved treatments are based on 2 clinical trials. One is Empower 133, which was comparing atezolizumab with carboplatin etoposide versus placebo carboplatin etoposide. As you see on the left, in the survival curve, there was an overall survival benefit where the median overall survival changed from 10.3 in the control arm to 12.3 in the experimental arm. And another important thing to highlight is at the 60-month mark, which is 5 years, around 12% of patients, which is the blue line here, were still alive in the experimental arm. 12% may not seem a whole lot, but for small cell lung cancer, it is a decent number that I would imagine, based on previous studies where we did not have immunotherapy, these patients did not survive as long. So yes, it's a small step, as I mentioned, but hopefully, as we try to understand which patients respond and why they respond, this is an important step in the right direction. The second study is the Caspian trial, which was durvalumab, which is another checkpoint inhibitor plus platinum etoposide versus etoposide platinum, the experimental arm. And again, the median survival increased from 10.5 to 12.9 months, so approximately a 2-month benefit. And at the 42-month mark, which is around 3.5 years, you see around 18% of patients were still alive, compared to around 6% patients at the 36-month mark in the experimental group. So the important thing to understand here is the benefit is approximately 2 to 2.5 months, and the 3 to 5 year survival is around 15 to 18% or 12 to 18%. But I think the important question is that what is the benefit in the real world population of patients that have extensive stage small cell lung cancer, given that in the real world, we often see individuals that may not have as good of a performance status functionally, or have other comorbidities, which may limit what kind of outcome or what kind of benefit they get from some of these therapies. Now, I think important to understand and highlight, there are approaches that are trying to advance how we can achieve more benefit in the maintenance setting, in the first-line setting for extensive stage small cell lung cancer. One of the trials to highlight is this IMforte trial, which is lurbinectedin, which is currently approved as a second-line or beyond option. It has an accelerated approval. It is a RNA polymerase inhibitor, inhibits protein synthesis. And in this trial, they're giving lurbinectedin with atezolizumab, which is a PD-L1 inhibitor, in the maintenance setting. So the design of the study is they have individuals getting 4 cycles of atezo plus carbo plus etoposide, which is the standard of care. And then patients are randomized to receive maintenance atezolizumab versus maintenance atezolizumab with lurbinectedin. And we have press release from October 2024 where they did announce that there was a potential improvement in survival in the combination in the first-line setting, but we don't have the data for this currently. And mechanistically, there have been some recent studies showing that lurbinectedin can induce damage to the DNA, can cause inflammatory signaling, which is why combination might benefit with checkpoint inhibitor therapy. But having given lurbinectedin or some of the other cytotoxic chemotherapies in the clinical setting, second line or beyond, these therapies do have side effects such as blood count issues, bone marrow suppression, infections, etc., that can be sometimes concerning. So it'll be interesting to see what this data looks like.